Well, hello, everyone, and welcome to the IMWG, the International Myeloma Working Group Conference Series, Making Sense of Treatment, based on all the wonderful things that we've just been learning about at the American Society of Hematology annual meeting in sunny and warm San Diego. So that just came to an end a little over a week ago. And with me today to discuss all this great research are three dear friends. Don't hold that against them that they're my friends, but three dear friends and wonderful leaders in the myeloma community. Beth Faiman is a nurse practitioner at the Cleveland Clinic. Dr. Nikhil Munshi is a myeloma physician at the Dana-Farber Cancer Institute. And Dr. Vincent Rajkumar is also a myeloma physician at Mayo Clinic, and he also serves as the chair of the board of the International Myeloma Foundation. Dr. Munshi will be joining us in just a few moments in person, and we're delighted that he's going to be with us. So I just want to take a quick moment to thank, in particular, our sponsors, Karyopharm and Regeneron, who have helped support this great program. And I want to thank all of our audience for joining us. We've had about 1,200 people register for this, and several hundred of you are already online. We know many of you are jumping online now, so we'll get rolling so that you don't miss anything. One of the things I think is absolutely fundamental as we spend some time dissecting the latest and greatest in multiple myeloma is that you'll hear a little bit of my opinion. You'll hear a lot of the opinions of Drs. Faiman, Munshi, and Rajkumar, but we want to hear what you're thinking as well. And so we have the opportunity here to send questions. We're going to plan to have this session of approximately an hour and a half, approximately 90 minutes. The first 70 minutes or so, we're going to be doing the discussion of various aspects of the latest in research in multiple myeloma, but there will be an opportunity to ask questions. If you don't get a chance to do so, or you don't want to do so now, please remember we are here at the International Myeloma Foundation to answer your questions. I didn't introduce myself as Joseph Mikhael, the Chief Medical Officer of the International Myeloma Foundation. And one of the things we spend a lot of time doing is trying to answer questions. Sometimes we answer them online in programs like this, sometimes in a video. But if you have questions, please either call the info line as you see here, email us at infoline@myeloma.org, or, as I'm sure all of you are connected to our multiple social media channels, be it LinkedIn, Instagram, Facebook, X, you can always submit questions to us. Just do the hashtag #AskTheIMF, or you can even do the hashtag #AskDrJoe. We will find a way to answer your questions for you because we are in an exciting time in myeloma. And whenever things are exciting and new things are happening, there are a lot of questions that get generated, and we're here to try and provide those answers for you. So please feel free to do so. And as you can see here, you can send them anonymously. This is being recorded, so for those of you who are live, welcome. For those of you who are already watching the replay, welcome as well. And please feel free to share this with others. We have a huge library of videos that can be seen if you go to myeloma.org, and we always want to have up-to-date information for you. So there's lots of information you can see here through our publications, our broadcasts, resources for healthcare professionals. Or if you really have a question, just ask Milo. If you're not familiar with Milo, Milo is the chat bot that we've now created at myeloma.org, and you can ask Milo questions and they will provide some answers. And then lastly, we really do want to have your feedback. So we appreciate very much how we conduct these seminars, how we carry them out virtually and in person. And please do provide feedback. There'll be a short survey at the end of our session today. Lastly, I want to give you a preview and a commercial for another similar workshop or seminar that we're going to hold in early January, on January the 8th. Tonight's program is open to everyone, of course, but it's primarily designed for patients who are really quite educated in the myeloma sphere, for practitioners, be they physicians, nurse practitioners, physician assistants, pharmacists, nurses, others that are involved in the care of myeloma patients. But we also host a similar seminar where it is really meant to be easy to understand at a patient level for those patients that may not be as familiar with all the things that are happening in myeloma. We want to make sure we provide education that's relevant to no matter what your background is. So I will be joined by Robin Toohey, who is our Vice President of Patient Support, along with 3 patients who attended ASH as part of our Myeloma Voices program. So these are really incredible patients. They're also dear dear friends of mine who attended so many of the sessions at ASH, and they were blogging and tweeting and vlogging and sending notes and educating others through their experience. And so we'll tap into their experience in a patient-friendly manner on January the 8th at 3 p.m. Pacific. So please mark your calendars for that. You don't want to miss that either. So let's dive into this annual meeting. So the American Society of Hematology is the largest hematology gathering around the world. We had nearly 30,000 people in person in San Diego and over another 3,000 that were virtually attending. And this year we actually had a record number of research abstracts that were submitted prior to the meeting that obviously get selected to be presented at the meeting. Last year we were around 7,500. This year we jumped up to 8,500. And perhaps what's most remarkable, and I will express my slight bias here, the fastest growing category and the largest category is multiple myeloma. More so than lymphoma, leukemia, hemophilia, sickle cell disease. All those other diseases, of course, are critical. But it is amazing to think that 1,200 of them were related to multiple myeloma. So I promise you we're not going to go through all 1,200 of them because that would take the rest of the day and the rest of the week. But what we've decided to do is to narrow it down to 7 mini chapters that we're going to review of key abstracts in different areas. And we're going to start with smoldering myeloma, then talk about frontline therapy for myeloma, maintenance therapy, what we do in early relapse, what we do in late relapse, the concept of MRD or minimal residual disease guiding the therapy that we have. And then what I often call patient-centric research. Of course, all research should be patient-centric, but these are as patient-centric, but this is specifically abstracts that demonstrate the great degree of patient engagement with a focus on quality of life. And we'll get to those towards the end of our program. So I want to start, and what we're going to do for each of these chapters is I'm going to introduce some of the slides and some of what was presented. By no means will we go through all of the data. And then I'll turn to our experts, to Beth, to Nikhil, to Vincent, to comment on them. And I'm not trying to suck up to Vincent because he's the chair of the board and a good friend, but he is the senior author of this paper. And if I were only allowed to show one abstract today, I would show this abstract. And I say that, as I say, not to be facetious about it, but this is clearly the most spoken about abstract at ASH this year when it comes to multiple myeloma, because this was a very large phase 3 randomized trial of patients with high-risk smoldering multiple myeloma. So of all the studies we're going to present today, I have more slides on this than all the others, but because this is one we want to dive deep into a little bit together. So a couple of things I want you to notice about the design of the study. Number one, who was eligible for the study? As we know, there are different categorizations, different risk stratifications to define what is high-risk smoldering myeloma. You know, we've changed the definition of myeloma 10 years ago that Dr. Rajkumar led, where we took what was the artist formerly known as ultra-high-risk smoldering myeloma and now have included it in active myeloma, essentially looking at those patients that would have been predicted to develop active myeloma within 2 years, at least 50% of them in those buckets. And so that's become part of active myeloma. But we still now have patients with very high-risk smoldering myeloma who are similarly at risk. And we won't go through them in extreme detail, but these are patients that have an M spike greater than 3, are of IgA subtype, have low levels of the uninvolved immunoglobulins, have a involved over uninvolved light chain ratio greater than 8, but of course less than 100, otherwise that would have been active myeloma, or have clonal plasma cells greater than 50%, but still less than 60%, which would make them active myeloma. So patients needed to have one of those factors. Point number 2 is they were randomized to either active monitoring, which I would argue is the standard of care currently, although there have been some previous studies that have looked at lenalidomide single agent, but have compared active monitoring to the intervention arm here, which was 3 years or 39 cycles, which takes 36 months to give because cycles are 28 days, of daratumumab monotherapy. And daratumumab was given the way we typically would, weekly for the first 8 weeks, every other week for the next 16 weeks, and then once every 28 days thereafter. Thirdly, I want you to notice that in the disease evaluation schedule, they were very meticulous to ensure that patients were imaged correctly. This is one of the criticisms of older studies that maybe didn't have careful imaging or used older modalities like skeletal survey. Here, patients had a CT or CT PET or MRI at least annually and a bone marrow every 2 years. And then, of course, patients were followed up very closely to see if they developed active myeloma with the primary endpoint of PFS, as you see here, of progression to slim crab criteria, as well as various other points looked at. Even before I show you the results of the primary endpoint, I think it's important to look at what happened to these patients during their therapy. And you can see that twice as many in the active monitoring arm had progressive disease, which is why obviously the study was terminated in those patients. And interestingly, there was a higher, as you would expect, number of patients that were discontinued by virtue of adverse events, but that percentage is only 6.7%. Which is considerably lower than what we've seen in other studies, speaking, I think, to the tolerability of giving daratumumab monotherapy. And then, of course, looking at other very critical endpoints, when we look at death on the study, we saw that actually there were fewer deaths in the DARA arm than the active monitoring arm here at 7.7% versus 13.3%, as you can see from the table. Again, if I could only show you one slide from this study, this is the slide. So whether patients had active monitoring or daratumumab, of course, a significant fraction of them ultimately, sadly, still do progress to multiple myeloma, or at least have the slim crab criteria of myeloma. But look at the difference between the two. Whether we look at 2 years or go out to 5 years, 63% of the patients with daratumumab remained in remission or remained without progression, whereas only 41% of those patients who had active monitoring. So the median time to progression in that group was 41.5 months. So we might argue that's a bit longer than the previous thinking around ultra high risk smoldering myeloma, but still at high risk. But it had not yet been reached in those patients that had daratumumab. One of the key questions we always want to know about this is, well, am I creating a sort of a super myeloma that if someone received that daratumumab for those 3 years and then progressed, maybe they're not going to respond to their first therapy for myeloma? So we looked at the PFS, the progression-free survival 2, meaning what was the outcome of that next line of therapy? And you can see that here it was not inferior for the daratumumab arm, if not even superior, as you see. And then arguably, most importantly, did this have an impact on overall survival? Is it one thing to just kick the can down the road, but did it actually have an impact on overall survival? And remarkably here, with a confidence interval that does not cross 1, with a hazard ratio of 0.52, we see that 93% of patients at 5 years are still alive in the daratumumab arm versus 87% in those patients that were actively monitored. For time's sake, I won't go through all of this, but we do anticipate that there are going to be more adverse events, as I intimated from the start, in those patients who were treated, including treatment emergent adverse events here that are higher, obviously. In particular, it was important to look at pneumonia, 3.6 versus 0.5%. So again, not absolute very high numbers. And we saw the deaths at grade 5 being similar, if not lower, in the daratumumab arm. So my last comment before I ask our esteemed colleagues to make comment is that there were 2 other studies. I won't give the data, I'll just show you the title. There are other studies that are also looking in this space. There was from our European colleagues a study comparing carfilzomib, lenalidomide, dexamethasone versus lenalidomide, dexamethasone, and even from Dr. Munshi's center at Dana-Farber of going even more aggressively, as it were, giving cilta-cel, giving CAR T-cell therapy for patients with smoldering myeloma. So that's a pretty lengthy introduction, but as I mentioned, this is the longest of the chapters that we're going to be looking at. And Dr. Rajkumar, Vincent, you're obviously the principal investigator here, or the senior author. I'd be very interested in your thoughts here. We don't necessarily have to answer these questions sequentially, but I'd like us to incorporate this in our thinking. Is this now a new standard of care in high-risk smoldering myeloma? Is there a simple way for our community oncologists to think about who is high-risk smoldering versus standard risk high-risk smoldering? Is there a way that we can help them through that? And then what other steps are part of our greater strategy of intervening early? It's not really all about just one study. Ultimately, we want to cure myeloma. Is this a step in that direction? And then lastly, at some point, I'd like us to think, what does this really mean for the clinic tomorrow? So Vincent, I've given you quite the introduction, my friend. So I'll let you comment about your thoughts around this study.
Well, thanks, Joe, for having me, and thanks to all of you who are attending this IMF event. And I'm really grateful for the introduction, Joe, for highlighting the Aquila trial, which is truly a remarkable effort, which went on for 10 years, the trial itself, but the precursor to that in terms of the work that was necessary to even start the trial goes back even more than that. So I'll just give you the summary of the 4 questions you've asked. Does it set a new standard of care in high-risk smoldering myeloma? I would say yes, because the trial has shown a significant improvement in all of the endpoints that generally matter to a trial like this. It prolongs time to progression to active myeloma, prolongs time to active CRAB features, prolongs the progression-free survival 2 or PFS2. Time to next therapy was prolonged. And it also prolonged overall survival. So if you're a patient with smoldering myeloma, there is no data that there is now data that using an intervention like daratumumab early will actually cause less deaths long term. And that's the real important thing. I mean, if somebody doesn't want to use daratumumab or some other early intervention, there is really no way to be sure that that will result in similar survival. Furthermore, all of this is accomplished with the finite duration of therapy and with low toxicity, as we have seen. Is there a simple method for risk stratification? The patients who were enrolled on Aquila trial, about 40% progressed in 2 years. We currently consider 50% progression at 2 years to be high risk, 50-50 risk of progression. So this is a slightly, has some slightly lower intermediate risk patients included. The classic way we are currently doing the risk stratification is the 20-20 system, where any 2 of the following 3 factors, more than 20% plasma cells, more than 20 for the light chain ratio, and more than 2 grams for the M spike. If you have 2 of the 3, that's considered high-risk smoldering myeloma. That is the population for sure needs early intervention. The intermediate group, somebody has to really put their judgment. Would they have qualified for the Aquila trial? And then make that determination. But the simplest way to risk stratify is the 20-20 system. Another method is to simply go to myelomarisk.com and plug in the actual numbers, and that spits out the risk of progression probability based on the continuous variable. But in general, there are many ways of improving the risk stratification that people are working on, such as genomics and things which will take time for clinical practice. It's more research area right now. What are that's the next steps to improve into early intervention. Also, another way to improve early intervention besides better risk stratification is to see one of the questions I get asked from a lot of myeloma clinicians who are not in the camp of let's wait and watch. That's a minority. Most of them are either wanting to do early intervention or want to treat it like myeloma itself. And that we don't have data for, so I would say that either DARA single agent or LEN single agent for a limited duration would be my preference. But there are randomized controlled trials ongoing comparing a mild treatment like this to a myeloma-like treatment with dara-lendex or isatuximab-lendex. The DETER-SMM trial is enrolling in the US, so if you really wanted to do more than this, you can enroll patients on that trial. It's available all over the country. The Ithaca trial, which looked at ISA-RD versus RD, has completed accrual and is waiting for analysis. And then what would I do in the clinic tomorrow for a newly diagnosed high-risk smoldering myeloma? I'll discuss the results of the Aquila trial. I'll say that for patients like this, we have done a randomized trial where we tried to watch them extremely closely versus give the data for 3 years, and we found that twice as many people died in the people who we watched extremely closely. That's really the bottom line. Forget the crab features and the risk of progression. There's no way to get around the fact that we had 2 times more deaths in the control arm for whatever reason, and that means you have to be careful that such a strategy of just watching, while it may be possible for some highly enthusiastic myeloma clinicians, is not real world. It's not real world in the US, and it's not real world in the world itself. Patients have a hard time getting into their doctor with the malignancy, let alone a smoldering myeloma. And so these patients will be missed and some serious harm will occur. That's why I would recommend to these patients, even the ones that I see, that this is the data, we recommend intervention, provided, of course, there's insurance approval, provided the drugs are available. Lenalidomide is very inexpensive in most of the world, and actually they can just use that instead. But we are hoping that the FDA will approve this, and then that will make it more easier to have this conversation.
Well, thank you, Vincent. As always, you covered a gamut of information in a very succinct and careful way. I do take your point very well. I think that there were many of us in the myeloma community who said, listen, why don't we just eliminate the diagnosis of smoldering and just, decide who really needs full treatment and who needs monitoring. But this really, I think, is going to open a lot of people's eyes and humble us that although we think we can monitor people really carefully and catch them before they, I always use the analogy of like running towards a cliff, right? Because I'm a runner, that if I'm running towards a cliff, hopefully Beth sees me because she's probably running faster than me anyway, and says, no, Joe, careful, don't fall off the cliff. We think we can watch our patients, but sadly, they end up coming into the emergency room with a broken bone, with renal insufficiency, with another issue. And that brings me to you, Beth, which is, one of the things that you are so well known for in the work that you have done and really set a high standard for us is the whole concept of shared decision making. And I wonder if you can drill down a little bit more based on what Vincent just shared with us around, the conversation that you're going to have in the clinic tomorrow when a patient comes in and meets this criteria.
So thank you again for having me. It's an honor to be here, of course. And it's funny you say the conversation I'll have tomorrow, because I had this conversation already 4 times this week, and I'm not even joking. So I have this MGUS consult clinic, and I've seen over 1,800 patients that I monitor regularly. And over the last 10 years, we now have people that fit that 2220. So I am in a unique position where I have all these patients, now that we have this Aquila study results that support the early intervention. So our standard of care is active monitoring. So annual bone marrow biopsies, if the proteins are still increasing, annual whole body imaging to really make sure that that patient doesn't need any treatment. But it's really difficult because now we have this wonderful daratumumab opportunity or lenalidomide, but for 2 of these patients that we talked about early starting, the insurance hasn't caught up yet because it's not yet approved. So now this is in an individual basis, but you have the discussion where you take the patient and the clinician and you discuss mutually all of the data and the opportunities for them. And so this is a very compelling study. I favor daratumumab because of its very good safety profile. Single agent lenalidomide, absolutely, there are data to support that. We do have the DETER-MM study available, so I'm trying to drive patients towards a well-designed randomized clinical trial when available and when they're able to. But I think having that discussion of shared decision-making is super important when you're talking about an early intervention such as that. So what am I going to do in the clinic tomorrow? The same thing I did today, discuss these options with the patient, discuss it with the healthcare team. And fortunately, we have regular tumor board meetings that convene that we can always discuss this with my colleagues at our institution as well. And we bring in community docs as well if they have difficult cases, which is really a nice feature. And I know there are a lot of other institutions around the country that have that opportunity as well.
Excellent. Well, thank you so much, Beth. Great comments. Just absolutely so important, right? That communication is critical, especially in the nuances of this. And going back to my TV days, this just in, Dr. Munshi is now with us. Nikhil, welcome, my friend. It's wonderful to see your face. It's great to have you with us. I know you've been listening into part of the conversation, and not to put pressure on our panelists here, but we have well over 500 people on this seminar right now, so on this webinar right now. So thank you for all of you who have joined. Thank you for the questions that are streaming in, that I know we won't be able to get to every one of them, but we'll work on some Q&A time towards the end. We were obviously going to spend a little bit more time on this chapter, but before I go to frontline therapy, I want to give you a chance, Dr. Munshi, to chime in. You've heard the data, you've heard how Vincent perceives it and Beth perceives it. Do you have any other thoughts around this Aquila study?
No, I think both of them. So first, thank you so much for having me here, and it's such a pleasure. And the 500 patients who are, or participants who have joined is your and this program's reputation that attracts them here. So congratulations to you for doing such a fantastic job. What I would be very brief about, and I think Vincent really summarized in a very balanced way, even though he's the PI, he put it very in a balanced way, what one should talk to the patient and give the options and discuss their study. The only one added point I would make, what this study has done, that it has established beyond doubt that an early intervention provides benefit in this setting. And it has set up a stage for how a study in this patient population should be done and how we can interpret the data. So I think this opens up the door for all the studies which are ongoing to follow the lead, whether we do a minor intervention like this one or do a more myeloma-like intervention. I think now the stage is set for those evaluations to be interpreted.
Beautifully said. And if I can just comment for a quick second before we move on, even just stepping back and looking the big picture, you know, part of what we have sought to do at the IMF, and you know, we so appreciate the partnership from you and Nikhil, and congratulations as the newest member of our board at the IMF. You know, the vision that the IMF has had for so many years is to find a cure for myeloma, and of course to support patients throughout it, that now every patient would live unburdened by their disease. That one of the ways that we're going to head towards a cure is intercepting it early, is intervening at the right time. We don't want to treat too early. We don't want to treat too late. I think this study is fundamental in that, not only to break down some of the maybe traditional thinking that some have had, that have been very hesitant to pursue this angle, but that I think it is going to be yet another step in the direction of being able to catch myeloma before patients have the terrible features of this disease of breaking bones and having kidney damage and the suffering that comes from it. So wonderful. Now, if we spend this much time on every abstract, we'll be here through the weekend, but this was really the important one, and I'm glad we did that. Let's move now to chapter 2 to talk a little bit about frontline therapy of myeloma. And again, I could have pulled so many different abstracts, and here I've really only selected a couple to comment on. We got an update on a very important clinical trial from our German colleagues, which was a quadruplet versus a triplet study in patients who are eligible for an autologous stem cell transplant. And in this GMMG HD7 trial, patients received isatuximab, another CD38 antibody, plus bortezomib, lenalidomide, dexamethasone, RVD, and a transplant versus just RVD and a transplant with no specific general consolidation. There was a potential for a tandem transplant. And you can see the second part of this study is shaded over a little bit because that's not yet been reported, but I think it's a brilliant design to then have a second randomization to see, is it worth staying on just lenalidomide maintenance alone or a dual maintenance with isatuximab lenalidomide. And we'll come back to this in chapter 3, because chapter 3 is about maintenance therapy. But this was really this was the first reported quadruplet versus triplet phase 3 trial that we had a couple of years ago when it initially reported, interestingly, with a primary endpoint of MRD negativity after that induction. And so we got an update on this study, which again demonstrates remarkable results, that the quadruplet, 2/3 of patients were able to achieve obtain an MRD negativity, whereas just a little bit under half with the triplet of VRD. So we see that benefit of adding isatuximab to VRD in that MRD status. And also now, with longer follow-up, we see this impact on progression-free survival. Obviously, we're going to talk a little bit more about MRD later, and Dr. Munshi has led and is leading many efforts in this area of having us appreciate the power and the value of MRD to predict, and also to potentially be used as an endpoint in clinical trials that can influence drug approval. But here, really quite strikingly, we see the benefit of this quadruplet versus a triplet, which I think I would argue really adds to our current knowledge of the quadruplet versus triplet world that we've seen both now in transplant eligible and ineligible patients. The Perseus study demonstrated to us with the DARA VRD in transplant eligible patients, and somewhat similar to this, isatuximab plus VRD has been demonstrated in the IMROZ study to demonstrate to be beneficial over a triplet, and was now FDA approved as of July of this year that we can use the quadruplet even in patients not going to autologous stem cell transplant. What I found interesting, though, the other study I wanted to include was the study led by Salomon Meunier in France, where the French group looked at it's not that I'm not interested in the results, but I'm interested even in the design of this study, where we see that these patients are given or compared daratumumab lenalidomide versus lenalidomide's design. But specifically, what I'd like us to highlight here is that in that green box in the intervention arm, those patients only received dexamethasone for 2 months. And I do think this is particularly important because it's not only feasible, but we'll see that there was a clear benefit here. Obviously, in one way, we could argue it's hard to compare DR versus R, because clearly there's going to be a benefit when two drugs are given, or two novel agents are given versus one. But I think it's speaking to the importance of dexamethasone dosing. And of course, Dr. Rajkumar led the study when we went from the old days of high-dose dex versus low-dose dex. We know that a myeloma doctor is young when they've never prescribed high-dose dexamethasone, right? What we sometimes call the myellennial. You know, the myellennial has never prescribed high-dose dex, has never prescribed thalidomide or oral melphalan. And these, in the old days, we would give 12 days a month. 12 out of 28 days, patients receive 40 milligrams of dexamethasone. And that study that Dr. Rajkumar, like the ECOG study, demonstrated the value of going from high-dose dex to so-called low-dose dex of 40 once a week. And now I think we're questioning really how many weeks do we need that lower dose dex. And I'm not being self-promotional here, but you'll see in the next couple of weeks an article in Blood where I had the privilege of writing the editorial. Suffice to say, the title of the editorial is Down with Dex. So I do think that there is an opportunity here for us, because although dexamethasone has a lot of benefit, it also comes with a lot of side effects. So as we come to think about quadruplet therapy, is it really quadruplets for all now, transplant eligible, ineligible? How does frailty factor into that? Do we now think actually is a patient quad eligible or transplant eligible? Is that changing? We've always been thinking in this modality, is it transplant eligible or not? Are we actually shifting our thinking now to saying it's quad eligible? Do we see a difference between the quads that are using daratumumab or isatuximab? Does it really make a difference between the two? And should we be embracing this down with dex movement? Should we be looking at opportunities to potentially more rapidly stop the dexamethasone in patients? And Beth, I'm going to give you the first kick at this, and then we'll come to Dr. Munshi. But what are your thoughts a little bit about some of these questions? Again, you don't have to answer them all, but potentially think through a little bit about whether or not we should be using quadruplets for all.
Right, and I come from the days in the early 2000s where lenalidomide was the new thalidomide, and we used that in a SWOG, what was it, 0232 high-dose Revlimid with high-dose dexamethasone versus high-dose dexamethasone. So I do come from those days where I wrote that prescription, and patients did not tolerate it. So I love the idea of the down with dex movement, not eliminating dex, but getting down to the best dose for the patient. There is value in some people with their disease kinetics to have dexamethasone. I like the idea of triplets, almost like an RBD light with an anti-CD38 up front. I also think that in some patients, we have the data with the smoldering, we have the data from the DR and the RD, just daratumumab by itself can really be a good drug for some people that are frail and not very fit. There is probably a difference between the DARA and the ESA, but I think just an anti-CD38 monoclonal antibody is very well tolerated in many different people. And again, just to circle back with the Down with Dex movement, I can't wait to read your editorial in Blood, but we do try to go to the lowest and best tolerated dose as fast as possible, because 360 milligrams of dexamethasone a month was not good for most people long-term in terms of the relationships. And we'll talk later on about some of the studies that we're now looking at quality of life, but that 360 milligrams and even 40 milligrams a week is too much for some people. So I'd love to hear Dr. Munshi's take on these studies.
Yeah, please, Nikhil, let us know. I mean, are you just pretty much giving everybody a quad now in your clinic in Boston?
Yeah. So, but that's very astute comment, and I do agree that the study you presented, and there are at least 4 other studies which are very similarly themed, comparing 4-drug versus 3-drug regimen, and in each of them, 4 has come out to be better than 3. So, in theory, in broader sense, 4 drugs are being used in younger patients who are transplant eligible, but also can be safely used in reasonably good proportion of patients who are beyond 70 who may or may not be considered transplant eligible, but they can tolerate it. It does not mean it is for all. So there has to be some consideration of frailty. And when we talk about frailty, one of the things we have to keep in mind that frailty is changeable. So when my patients are diagnosed with myeloma, frailty could be because of comorbidities. They could have heart disease, they could have kidney disease, other things. It also could be a little bit related with age itself. But then frailty also comes with myeloma disease itself. And so one of our colleagues who is specialized in geriatric medicine, he has done studies where giving treatment to patients can overcome some level of frailty. And based on that, in an earlier study, it showed that if patients get 3-drug regimen compared to 2-drug, even in a more advanced frail patient, 3-drug provides better benefit because their frailty improves, their tolerability improves. So to summarize what I just said is that very large majority of the patient would benefit from 4 drugs. There is a small number of patients with frailty, either comorbidity or purely age, who can be started on 3-drug regimen, and then considering the response, one could see if addition of 4th drug is necessary or not. Quite often it is not necessary in those patients without adding toxicity. The second point this study highlights, Joe, and what you showed was very important, is that with 4-drug regimen itself, without transplant, without anything, more than 50% of the patients are able to achieve MRD negativity, and or at least 50 or thereabout. And so this is very important that a large number of patients would be able to get deep and what we would call durable responses. And I think we have to keep that in mind as we use these drugs, at what time, how long to give, and when to consider the next phase, which is the maintenance phase and or consolidation phase. The third point, I think your Down with Dex is a very good, timely consideration. I think Vincent had the first Down with Dex in the old days, decreasing from really super high dose to tolerable dose, and now we are getting below it. Dex has a role, so the study you showed about Salomon Manier's study gets a little bit of Dex. So is it 0 Dex? Probably not, but a lower dose of Dex may be good enough, and we'll go from there to see if 0 Dex is okay or not. And so lower dose, which patients really love, more than patients the family love, and the patients don't get Dex for obvious side effects, and that would be. And the last point that your question here is DARA versus ESA. I think as far as response is concerned, outcome is concerned, I think both should be considered reasonably identical. Their binding sites are different, so the theoretically in the lab we can see if one doesn't work, would other work or not. That data we don't want to parse today. However, the difference currently is that daratumumab is subcutaneous, isatuximab is IV. Both provide very similar clinical benefit, and I think that's what we should keep in mind.
Excellent. Before we wrap up, Vincent, I'll give you a last word if you have an additional comment.
The only comment I do is just with the dexamethasone dose, even though it's important, I would say that we are careful in how we do this. I mean, the reason we use dex is because it does have anti-myeloma activity and not for managing side effects. It has a single agent activity of like 40% by itself, and therefore I like Beth's comment, like, you want to lower it as quickly as possible to the best tolerated dose and see if you can stop it. If you're not going to use it at all, then I would say you want to rely that on data like this. The patient
Agreed.
where you only want to give 2 drugs and you don't even think you can give 3, and it's a choice between RD and DR, that's easy. If you can get away with the triplet, then do you really give only DR or DRD? That has not been tested. And so we just have to be careful about how we extrapolate. And the final thing is there are some patients who are unable to tolerate even 1 drug, even 2 drugs. And there, I think DARA single agent would be really good. We were surprised with the 60+% response rate for single agent DARA. That's the first time a newly diagnosed patient has received nothing but 1 drug. And in the relapse and in all other settings, DARA has only a single agent response rate of 35%. So there might be some patients, you give the 1 cycle and then you can move on to the full-blown treatment because their performance status improves.
Yeah, I completely agree with all of you. And I think as we go forward, we just remember, what does DEX do? DEX has an anti-myeloma effect. It has an anti-administration reaction effect. It has an anti-nausea effect, and it has an anti-pain effect. So there is benefit from it. I don't want to necessarily throw out the baby with the bathwater, as it were, but I do think that sometimes I've drawn for patients, it's like the booster rockets on the shuttle. It does seem to be very synergistic and helpful early on, but we need to, with time, taper, because the relative benefit may be lost with the increased toxicity over time, especially now as we're using quadruplets in many patients. But more to come with that, more discussion. I love that we can't solve everything here today, so there'll always be more discussion. But let's move on now, because we're still, in a sense, the frontline therapy, but we're moving to think a little bit about new approaches to maintenance therapy. And this is where, again, I think there's still a fair amount of equipoise here. There's still a lot of challenge. We saw originally, you remember, of course, the Perseus study that we quoted, one of the 4 studies that Nikhil commented on as being a quadruplet versus a triplet. And there was sort of an interesting design to the maintenance part. We've always kind of focused on the 4 versus 3, but here there was an interesting design. I won't go through it in extreme detail, but patients were in the triplet arm were given just lenalidomide maintenance till progression, but in the quadruplet arm, they were given DR for up to 2 years of daratumumab, mitigated by MRD positivity, and then would continue the lenalidomide by itself. At ASH this year, as we did at the International Myeloma Society meeting, we saw the Auriga study presented, which was comparing daratumumab and lenalidomide in a randomized fashion to just lenalidomide maintenance. Interestingly and importantly, though, I would comment here that these are patients that had not seen daratumumab before. So in one way, you look at this and say, well, is it applicable to my patient? Because almost all of our patients now are receiving a CD38 antibody early on, but it is demonstrating the benefit, the increased depth of response when we add daratumumab to lenalidomide. And then I tossed this in kind of out of interest. It's not ready for prime time yet, but I thought it fascinating that one of the European Myeloma Network studies was now even looking at adding teclistamab to lenalidomide in a maintenance setting. Obviously, this needs more development, but it was actually comparing tec-len to tec alone to len alone in these 3 arms. And so it begs the question a little bit more, is lenalidomide maintenance therapy enough? I mean, it is the standard of care. It has improved progression-free survival. It improves overall survival. I remember when that JCO paper came out, and Vincent, I think you wrote it with me. We wrote an editorial for that where we talked about the fact that lenalidomide seems to have such a prolific impact. It really is the standard of care after transplant. but there was a bit of a challenge in those patients with high-risk disease. And so there have been a lot of centers that have looked at this differently, that routinely add a second agent in maintenance, be it a proteasome inhibitor of bortezomib, based on early studies, a proteasome inhibitor of carfilzomib based on the Forte study, now giving daratumumab based on Perseus and originally the Griffin study. So I think there are still questions that need to be answered. And I'm interested in knowing from this group, is dual maintenance really the standard of care? Are you giving it to everybody, standard or high risk, or are you only giving it to high risk? Do you add a PI to it, or is the monoclonal antibody? As I say, do you make a difference based on high risk? Do you treat until progression or intolerance, or are you now saying, and we'll come to this in our next section, that's why they're sequential, to talk about MRD guidance? Do you say, oh, if someone's MRD negative for X period of time, do we stop? And maybe we'll hold that last question until we get into the next chapter. But Vincent, I'll let you respond first, because you've been so involved in many of these studies as well. You know, are the majority of your patients now being treated at Mayo? Are you giving dual maintenance, or are you sticking to Len and adding something to it in certain contexts based on the, you know, somewhat incomplete data we have?
Yes, Joe, thank you. So the main thing is you've already shown two trials. The Perseus trial gave the Dara-Len only to the Dara patients and Len to the Len VRD induction patients. In contrast, the GMMG study that we previously discussed has two separate randomizations, the ASA VRD versus VRD, and then both groups are randomized to either getting Len alone or Len plus ISA, which is the type of design that will tell, do patients who have already received a CD38 in the induction setting, do they benefit from more of the same in the maintenance setting? And we don't have answers to that yet. We do have a trial that is ongoing in the US that is looking at all patients with multiple myeloma who are finished transplant and are on maintenance with and have reached needing maintenance, Len versus Len plus Dara. That is also not read out yet. That is actually still accruing. So in my mind, Len alone still remains the standard of care. There's an ongoing NCI trial looking at Len versus Len plus Dara. The Perseus trial didn't ask the right question. We have to wait for the GMMG. Auriga is not previously CD38, and I cannot use that either. So we are left with hardly any data to be sure that adding the Dara for all patients is worth it. And so I'm not all in the Dara camp, as you can see from, unlike the Aquila trials situation. But the other questions you've given are all clear. You know, I think dual maintenance has become more or less standard of care for the high-risk patients, not all patients. In terms of which one to add, I'm torn. I think either one is okay, a CD38 antibody or PI. I prefer PI, but I could be pushed the other side. Yes, we do treat based on risk status, and we treat at least for 3 years, and then after that based on tolerance and decide. That's what the UK MRC study showed. And then we have got studies going on right now looking at whether we should either escalate or de-escalate based on the MRD result while on maintenance.
Can I ask just quickly on that, Vincent, do you think that UK study, not that we showed the data today, but for those who may be familiar with it, you know, the longer term follow-up of lenalidomide versus placebo, do you think it actually demonstrated the value out to 4 years or really to primarily 3 years?
No, actually till 4 years, you're right. And they basically showed that you could potentially have benefit as long as 3 to 4 years before it started to go down. Most people can take Len only for 3 or 4 years anyway. And if they're tolerating it extremely well, I don't have a problem continuing. But if they're having problems, then that might be the time you would have a conversation about whether to stop and see how they do.
And Beth, maybe you can comment on that, because, you know, you and I have done many of these kinds of sessions together, especially with patients. Obviously, we have a lot of providers and physicians listening tonight. I think we're up over 550 now. But we also have patients listening that, you know, I say it all the time, we don't treat myeloma, we treat people, that we don't want our patients to be suffering over long periods of time with diarrhea or infections or fatigue or muscle cramps and the like. Just maybe you can comment for a minute on the importance of ensuring that we don't just look at a patient and say, Well, Dr. Rajkumar said that 4 years is good, so you'll take it and you'll like it. That we have to have this conversation to ensure that we check on their, not that you're saying that, Vincent, I know you're not saying that, but I'm just making sure that we remind our clinicians, because sometimes I see these patients, I'm sure you all do in consultation, where their spouse looks at you and says, she doesn't leave the house anymore because she's so worried about, diarrhea, for example. Not that it happens that commonly, but even in those large maintenance studies with lenalidomide, approximately 30% of patients had to come off. So Beth, I wonder if you can comment on that for a minute.
Yeah, absolutely. So our standard of care is still len maintenance, maybe a proteasome inhibitor for high-risk disease. We are accruing to the SWOG 1803 study with the DARA R versus the R, and that's really where we're pushing our patients to, or not pushing our patients, but encouraging them to participate. And we're asking all comers, doesn't matter how you got into the remission and transplant, it's what do you do afterwards. As far as the length of therapy, the UK Paulwin data with the MRC trial now suggesting about 4 or 5 years. And we're having that discussion since this came out. I think it was last year, I started becoming quite interested in these data. And so these are common conversations. Patients are now 5, 10, 15 years on lenalidomide, whether they had transplant or not. When do you stop? Mayo Clinic and others had other studies. So again, it's that shared decision making where you discuss with the patient, what do you want to do? These are the data that suggest that maybe we can stop. In my practice, a lot of times I recommend, let's make sure you're MRD negative or have a low burden of disease. Let's make sure that your imaging is negative so that we can really say, you have no evidence of active myeloma, and that makes me feel reassured. Is that the standard of care? Not necessarily. Some providers will just say, let's just stop if it looks like you're in a serologic remission. Part of the challenge is you can't obtain an MRD negative marrow. If their original bone marrow was from 2008, it might not be good enough quality to determine if that patient is MRD negative or not if you're comparing the clones. So again, having the discussion with the patient, I don't know if they're going to need treatment again, but now we have all these wonderful drugs and an armamentarium available to treat them. So maybe they do need a well-deserved break, but establishing trust and managing the side effects the best you can while they're on treatment is super important.
I think that's just so critical because very often that dose reduction does make a difference. And I'm going to come to you in just a moment, Dr. Munshi, because you are, I think of you as one of the MRD gurus when we come back to this question about MRD guided therapy, because I really think that is going to be helpful to us. And both Vincent and Beth have intimated to it. But before we jump into that, let's talk a little bit about early relapse, because this may be one of the other major breakthroughs in myeloma right now. I mean, it's hard to temper the enthusiasm when we have so many different things happening in myeloma. And this isn't brand new data, because we did see a lot of this earlier in the year at ASCO and at EHA, but we did see some updates in particular from Vanya Hungria from Brazil, who's one of our scientific advisory board members at the IMF, and whom we've worked with very closely for many years. She led the phase 3 DREAM7 trial comparing a triplet versus a triplet, right? I mean, we've been commenting already today that 4 is better than 3, and often 3 is better than 2. Well, what about 3 versus 3? And I give credit to the design of this study and the DREAM8 study, which was similarly belantamab Pomdex, versus bortezomib Pomdex, similar design that not only showed an improvement in progression-free survival, but really an overall survival benefit. In this case, belantamab bortezomib dex versus daratumumab bortezomib dex, and quite impressive curves, to say the least, with median overall survival not being reached, especially in an agent that, of course, had a previously negative study in DREAM3 and was withdrawn from the market. Although many of us still have a lot of our patients on belantamab and see the value of it. We'll come to the challenge of the ocular issues in a moment, but really quite impressive data here, which again, going back to ASCO earlier in the year, we saw similarly with the DREAM8 study, where we saw, again, this other randomization, as I mentioned, triplet versus triplet, belantamab Pomdex versus bortezomib Pomdex, maybe a combination that we may be more attracted to here in the US, where we're using more pomalidomide in that relapse setting. But also, by contrast, we now have had updated data from Rakesh Popat shared with us the updates in the, we've just been talking about MRD negativity, but of the power of the CARTITUDE-4 trial, which was, of course, comparing the intervention of cilta-cel in earlier line therapy, 1 to 3 prior lines of therapy, compared to the triplets that we typically use, and showed, as we've seen now in this study, improvement in response rates, including MRD negativity, improvement in progression-free survival, and even indeed in overall survival. And then lastly, I tossed in out of interest that bispecifics, which are now primarily used in much later line therapy, FDA approved only for patients who've had at least 4 prior lines of therapy. But we saw a whole series of studies, this is just one of them, that is now introducing earlier line bispecific antibodies, in particular here in combination, in this case, teclistamab added to daratumumab and pomalidomide, so really a quadruplet with some early but promising results. So Nikhil, why don't we start with you? I mean, how do you think you're going to incorporate belantamab now? We can target BCMA with a CAR T. We can do it with which you led. We can do it with bispecifics. We can do it with now belantamab. How do we think this is going to happen? We'll come back to the optimal dosing in a moment, but maybe you can talk about that and also answer the question, who are you giving CAR T cell therapy to at first relapse? Because I know Vincent has some very strong opinions about this, which is why I want to start with you and get both sides. But how do you see this happening, Nikhil?
Yeah, we hopefully will have similar views, but let's see. It's a blinded study. So I think one of the things you are highlighting is that BCMA is an important target to go after. Whether we are using cilta-cel, we are using teclistamab or belantamab, that has become important component of our treatment, second line and beyond for sure. And there are studies in newly diagnosed, but at least for today, it is a very standard of care. So what the question you are asking very astutely is, which of the 3 BCMA targeting agents we should be using earlier? I'm not saying second line for everybody. However, which one should be using earlier? And there is emerging data, not black and white, but emerging data that suggests that of all the agents we have, the CAR T cells, bispecific, and belantamab, CAR T cell has probably the best response and a more impressive duration of response. And so of the 3 agents, if I'm going to pick up, I would use CAR T cell first, if available, if various other factors, including financial aspects of it, the feasibility of doing it in a given center, et cetera, the experience of the investigator, I think that might provide the best benefit. There is also data that the response to CAR T cell goes down if there is a prior exposure to, for example, bispecific. So sequencing-wise, CAR T first followed by bispecific and or belantamab may be more appropriate, partly because BCMA expression is downregulated, not necessarily lost. BCMA loss is not the most common mechanism of resistance, but some of that effect may be observed. So sequencing-wise, I would go that first, and then we can think about either belantamab or bispecific. One thing to keep in mind, that bispecific and belantamab, they work through very entirely different mechanism. They are targeting BCMA, but they're different drug. One is our traditional chemotherapeutic drug being specifically delivered to myeloma cells because of BCMA expression. So the mechanism of resistance and sensitivity is driven by the chemotherapy that we give. On the other hand, the bispecific is really co-opting the immune cells in the body and then to have anti-myeloma immune response through T cells. And so that's very different than belantamab. So resistance to one does not translate to resistance to other. And I would be quite comfortable in using belantamab post-CAR T cell relapse, etc. Should everybody get bispecific as a second line? Just one more, because that's a randomized study you are doing here. And my answer is no. I think we have traditional confirmed therapeutic agents that functions very well. For example, if patients relapses after DARA RVD, I would have no issue starting patients on carfilzomib, Pomdex, or some such combination for them to get a true second-line responses, and then we utilize CAR T cells. Because after all said and done, the responses, even in late line for CAR T cell, is outstanding, 98% at 6th line. So we can still utilize later on. And duration of response is very impressive for that as well. And there are toxicity concerns that we have to keep in mind. The neurotoxicity, the cranial nerve palsy we see in earlier lines of the study, very infrequent T cell malignancy, etc., or MDS, etc. So I think keeping those things, I would not say I would go for CAR T for everybody. However, there are high risk patients, there are patients with certain features where I would consider them earlier on because they might need much deeper cytoreduction that they may or may not have gotten with earlier treatment. I would
My
stop there.
suspicion,
We can talk a lot.
it absolutely, I mean, my suspicion is that all four of us actually very much agree on this. Vincent, would you like to chime in a little bit about where you might see belantamab having its place, and in whom will you give CAR T its second line?
I think, I completely agree with Nikhil on all of these aspects. So like he just said it, I don't have anything to add. As far as belantamab, once it is approved, it is one of those drugs, if we use carefully and correctly, even one dose, sometimes patients have a very aggressive myeloma that you want to control quickly and then take them to CAR T or bispecific, and you don't want to do it with high tumor burden. And now we are really struggling with what's the best bridging therapy, and sometimes, we may be in a situation where you could give belantamab one dose or two doses, get the disease down and then proceed. Or it may be one of those drugs where you could get away with 3 or 4 doses a year and control it. So there will be places in which, I couldn't have said it better. Nikhil said it. This is not like immunotherapy. This is regular chemotherapy in the form of like a monoclonal targeted delivery with belantamab. So the patients who don't respond to one or the other would probably respond to belantamab and vice versa. So we have to keep that also in mind. So I think it'll have a role, but the key is, can we give it safely without causing visual problems for the majority of people, and really dose it correctly? This every 3 weeks is not going to work. So we have to figure out, maybe give it 1 or 2 doses like that, and then quickly move to once every 3 months or something. Something will work out. Like dexamethasone and bortezomib, we'll work it out.
Yeah, absolutely. I mean, I think one of the key lessons here is every drug goes through an evolution, right? To become more efficacious and to become safer at the same time. And I think that's what we're learning. And I say it all the time, Vincent, you've heard me say it, Beth, you probably heard me say it ad nauseum. There is no drug in myeloma that we use exactly the way it was first introduced. I remember the days of giving 800 milligrams of thalidomide. You remember the days of giving IV bortezomib twice weekly. I mean, everything goes through that evolution. And Nikhil's point about the potential neurotoxicity is important. We're going to come to that in a moment when we think about another CAR T. But above all, do no harm. I think we have to be careful, even if it's a very small subset of people. But there's no doubt there are patients with very high-risk myeloma, especially that functional high-risk patient in which we may want to introduce it. And I think you said it so nicely, Vincent, about belantamab as well. We have a working group, as you know, within the IMWG working on this optimal dosing. I mean, I have several patients in my clinic now where I just give them a drug every 3 months. It's amazing. And they've got such a great response. And we want to be able to, because I do think that, remember, 80% of myeloma patients in this country are treated in the community. There are going to be people that are simply not going to have access to CAR T, or even, at least in the short term, bispecific antibodies. And very often, especially an older, more frail patient, I think with the right dosing, we can use belantamab. Beth, final comment before we jump into our next session.
Briefly, I'm dying to comment on this. I love belantamab. It's an antibody drug conjugate, toxic payload. It's easy to give. And if I want to do a BCMA-directed therapy for a patient, this is great for the community. Just as I've heard here, sure, the eye exams to assess for baseline and after, before each treatment were kind of a bother. But I had so many frail patients that were Jehovah's Witnesses, patients that couldn't deal with the cytopenias. This was a perfect drug for them. And so I think it fills an important gap. You can give traditional therapies with an infrequent dosing of a BCMA therapy. And just as Dr. Munshi mentioned, the BCMA target is a very important one, and this is a drug that we can use to fill that gap.
Excellent. Beautifully said. Beautifully said. Well, we have 3 more chapters and about a half hour left, so we're going to shorten these chapters a little bit. Of course, we could have a whole session on late relapse. I mean, how many things could we discuss? But I would suggest if there was one abstract in the more heavily relapsed setting that gained a lot of interest, was this presented by Kira Freeman, who I've had the privilege of working with for a long time, of the Anita cell study. So this is now a CAR T cell therapy that in roughly the first 100 patients had a 97% response rate. So very dramatic response. You can see the fraction of them that achieved CR or greater. And interestingly, obviously the numbers are still a little bit early, but we've got a progression-free survival rate at a year of 78%, 96% of them alive at 1 year. And importantly, with generally manageable as we would typically manage a cytokine release syndrome. And perhaps most striking was this slide when it was presented, because at least in this first cohort, and I know it's still early, they had no delayed neurotoxicities or non-ICANS neurotoxicities, such as that very small percentage, but worrisome percentage of individuals who may obtain Parkinson's disease, Guillain-Barré, or certain neurological toxicity. So this, I think, was a signal to us that we have other CAR Ts in the mix, and other ones I could have mentioned that had even dually targeted CAR Ts. But I think it's pointing us in the direction that we may be able to, with the right design of the molecule, possibly not only maintain the efficacy we've seen with CAR T, but potentially reduce its toxicity. We also saw, if you will, a novel set of bispecific antibodies. I've selected 2 of them. The artist formerly known as ABBV383, which is now a 10-to-mg. So in 10-to-mg is a little bit different in that it's a bispecific antibody that does target BCMA, but from its start, it's designed to be given once monthly, once every 4 weeks. It's designed to be given exclusively as an outpatient, either with no step up or possibly 1 step up. That's a question that's being evaluated, and we saw some data in the Kilimanjaro study of even combining it with daratumumab. The other bispecific that we saw new data from Josh Richter was the cevostamab study. And so cevostamab is another bispecific antibody, but now targets a different region. So we've had BCMA targeted agents, GPRC5D, and now for the first time FCRH5. And so even in patients who had a previous exposure to BCMA, we saw about a 40 to 45% response rate in that group. And interesting, there were a series of studies helping us to provide the best symptomatic management or best symptom management that we see. Are we moving like our friends at Emory, who've gone pretty much whole hog of giving everybody tocilizumab as prophylaxis before giving bispecific antibodies like teclistamab, elranatamab, and talquetamab? And so we are seeing, some interesting work being done here. I still think that we're in that evolution phase, as I've said, we're in that learning curve. I think we're probably using this agent a little bit more aggressively than we were 12 months ago, but I'm not sure everyone has yet bought into actually truly using it prophylactically before we give the drug, but perhaps giving it even at the earliest stage of CRS. But this was really quite interesting data. So great questions here for us to think about. But is anito-cel, will that be the next CAR T cell therapy? Do we think that this efficacy and safety profile makes it a little bit more attractive? What do we think about these newer bispecifics of etentamig and cevostamab? How are you using toci or tocilizumab in cytokine release syndrome? And maybe Beth, I'll come to you for a moment in that. Are you at Cleveland Clinic? Are you just giving it right up front? Or are you waiting to have even grade 1 CRS? And what other things? I mean, I didn't have a chance to go through all sorts of other molecules. We have cell mods coming. We have other new CAR Ts that are coming, new combinations and relapse we haven't seen before. There was a selinexor carfilzomib study that I thought was interesting. I mean, there's so many different studies that are being looked at. But maybe I'll start with you, Beth, if you have any comments about any of these questions that are listed here.
Right, and it just dawned on me that we could be here for 5 hours and not go through all the questions or all the modules. And so I'll be very, very brief. So anito-cel is very attractive CAR T cell therapy. I'm not sure how it'll fit into the treatment paradigm because we are so comfortable with the cilta-cel and the ide-cel currently. So stay tuned. I won't talk too much about that. I love cevostamab, a new target. Our patients need more targets because the more drugs we have, the more newer targets we need with interesting mechanism of action. And tetomid, the ABVV compound, is also very interesting because they're combining it with the daratumumab. We do not use profitosi. We had the 53 patients from Emory. Sarah Scott had published their paper for profitosi, and then now we have Miami adding to the body of evidence with their 73 patients, but I don't think it's ready for prime time yet. I think ongoing studies, you're still seeing grade 2 CRS. We admit all of our patients, and that's how we manage our CRS. And we partner with the community. We don't want to keep these patients for bispecifics. We want to send them back to the community so they can receive the drugs in the community where they're designed to be given. And then other approaches and molecules I'm excited about. Too many to mention. I'm going to hear from Dr. Rajkumar and Dr. Munshi on those topics, I'm sure.
Vincent, what are your thoughts here?
Oh, exactly the same. I like the word profitosi. I've not heard that before. That's interesting. I think you've covered all of it. I think the anito-cel data was good. We also had the tri-specific antibody presented at the IMWG breakfast meeting. That's coming too. So yeah, lots of interesting data. Nikhil?
No, I agree. I think anito-cel's role would be, it will be initially hopefully approved for fourth line or beyond fourth line treatment. So we'll have to find its role, but what is really impressive is very high response rate, good CR rate around 60%, 62%, MRD negativity, and PFS seems to be pretty good. Currently, feels like it will be more than 2 years. So I think it's going to be an important component with much reduced neurotoxicity. I think that's a clincher, that no concern about neurotoxicity. For quick comment on cytokine release and TOSI, we don't use it prophylactically because you don't need it in everybody. It's expensive, it's unnecessary, but our threshold to give it is very low. So if patients get fever, that is used quite easily, quite quickly, but not give it prophylactically.
And then there's always that in between. I always think of Tom Martin, who says, we don't necessarily wait for a fever. We say, are you feeling a little feverish? Are you feeling a it's sort of grade 0.5 of CRS. But I think, as you mentioned, Beth, we'll have more understanding with time as the data is built to determine if it's worth doing or not. Okay, let's come to our last two chapters. And I want to get to some of the now over 40 questions that we've received. MRD guidance. This is where I'm going to call on you in just a moment, Nikhil. I'm not even going to show the data. I'm just going to show the titles. I thought there were two particularly important studies. One from our colleagues in Greece that had looked at sustained MRD negativity for 3 years as being an opportunity to discontinue lenalidomide therapy, as we had a little bit of a discussion earlier. And then, of course, further information from Luciano Costa at Alabama, who's given us great work in the master trial, initially helping us understand that MRD negativity is powerful. We get concerned about those ultra high risk patients who may achieve MRD negativity and lose it. And he showed some interesting data about actually noting that MRD progression really was a harbinger of true IMWG progression to come there afterwards. And so I'm leading the witness here a little bit, Nikhil, but is MRD important in myeloma? Are we ready to make clinical decisions based on this? For a lot of our community clinicians listening in today, this may be the one critical question that gets asked all the time is should they be ordering MRD testing on a regular basis, and what do they do with that answer? And then, of course, I know you're particularly interested in that final question about the design of trials, but maybe for time's sake, I'll let you comment on these only, and then we'll move to our final chapter. But just interested in your sort of global thoughts around MRD and how we should be using it in myeloma.
So Joe, this is very timely. And again, we might need a whole hour and a half to deal with MRD. And just because of your first question, I think it has become critically important endpoint, not just for clinical study and drug approval, that's a different deal, but for our clinical management of the patient. And what, if I briefly summarize it, I think it's important for prognostication. Patient getting MRD negativity are going to do well. So we can give that clear prognostic endpoint to the patient that you are in a very good group. Even high risk patient, when they become MRD negative, their outcome is significantly improved. They go very close to standard risk. So I think that's a very important endpoint. The second question here, what you are raising is very critical, important too. Do patients need consolidation, transplant, for example? And there are many nuances to it, so I don't want to give a blanket statement. However, decision to postpone transplant is quite often done based on MRD negativity or not, because our multiple studies have shown that if you are MRD negative, it doesn't matter how you get there, with or without transplant, your outcome is going to be better. So I think that's what is driven. The study presented here in ASH and also in the past shows that we can decide, tailor our treatment based on MRD negativity, especially if you want to stop maintenance. I do it in my practice when patients have been on Revlimid for a long time. Some toxicity, there is always toxicity beyond certain time point. This guides me to see if I can comfortably say, well, let's stop it and get you over the side effects. And then in high-risk patient, it's even more important to do that. Opposite to that, what Luciano showed about MRD recurrence, there's a very good Norwegian study ongoing, which is going to take a while to mature, where they are showing that early sign of MRD negativity. Should we change the treatment? Today, I do not. However, in high-risk patient, I think the algorithm is a little bit different. We will have a much shorter threshold to do something, and the Norwegian study would guide us whether doing early intervention when MRD negative becomes positive is going to give us a better outcome. So not a blanket statement there, but in high risk, if they become positive, I would be very much more careful in deciding how quickly should I now change the treatment or institute a new treatment.
Excellent. I think you've summarized a complicated area, because I do want to make sure we don't leave this message that MRD negativity means you can stop, because it is one piece of evidence in the bigger picture, as you've described, especially in the context of risk status. But at the same time, it behooves us with time. I joke and say my favorite treatment, Nikhil, is nothing, nada, right? And if I can find a way to get people down to giving them nothing with the evidence to do so, then obviously our patients will benefit from that.
And Joe, one question that was asked that I read while we were talking, somebody said 10 to minus 5 versus 10 to minus 6. Yes, 5 is approved for drug approval and those kind of things. And that's what will be important reported. However, we know, as the person who asked the question, 10 to minus 6 is better than 5. We can't get it in everybody. That's why it is not a standard endpoint for drug approval. But in my clinical practice, I would try to look for 10 to minus 6, because that is deeper, that's better, will give us better outcome.
And it makes sense, that iceberg concept, right? The lower you can get, the less disease left, the better the outcome. Well, let me introduce this final chapter, and then we'll take some of these questions. Thank you for already answering 2 of them in your answer, Nikhil, which was great, because we've seen lots of great questions come in, and we'll come to those in a moment. But what I call the sort of patient-centric research, of course, all research is patient-centric. I mean, we are really all about our patients, and so we should be. But I just thought there were some very interesting things that could really influence the patient's quality of life right away. One of them was presented by Dr. Rahul Banerjee from the Fred Hutch, which was looking at really the value of 24-hour urine testing. Now, we know we've been discussing this as an International Myeloma Working Group, and with the potential to modify criteria of how we routinely have to check for urine. But he did this study looking at really how impactful was doing all of those 24-hour urines. And I do like how he showed this picture. I didn't show the picture on this one, where he showed a picture of an open fridge with the urine container next to the orange juice, which made the point that these poor patients are collecting urine over 24 hours, keeping them in the fridge, recurrently doing so. And do we really need to do that with now our sophisticated measures? It reminds me, Vincent, of the editorial that I had you review for me when I was at Mayo Clinic, looking at the French study that compared urine testing versus serum testing in light chains, and we entitled it "P No More." Are we getting to a point where, thankfully, we might be able to have fewer of our patients constantly repeating 24-hour urines, especially if they don't have a significant proteinuria? Dr. Urvi Shah from Memorial Sloan Kettering presented some of her fascinating work. She's dedicated so much of her life to nutrition, and this is a question that's already come up in the Q&A here on the side. Every single IMF educational program I do, the question of diet comes up because people want to have something that they can control. And we're not suggesting that the diet is going to immediately change your myeloma, but there is some evidence here. As we know, there is a connection. We don't fully understand the connection, but there is a connection between obesity and multiple myeloma. As we try to understand what causes myeloma, we know that those of us of African descent, for example, like myself, have a twice as high risk of obtaining it. There are certain exposures we know are connected to myeloma, like Agent Orange, and firefighters, for example, who have been exposed to toxic fumes, or first responders. Even at 9/11, we learned about a greater incidence of myeloma. So as we understand that, we want to look at what could be modifiable. And I thought it was fascinating that Urvi is doing this work both in the lab and in the clinic to see if certain dietary interventions may delay the progression of myeloma. Ashley Roscoe from Ohio State University, who does both geriatrics and myeloma, just an incredible individual, is committed to this, presented these are all oral abstracts, by the way. It's just fascinating to me that she presented this concept of lovesick, where she demonstrated the interplay between an individual who's having a stem cell transplant and their partner. And the influence and the behavior that affects both of them. Because, we said it so many times already today, we don't treat myeloma, we treat people. It's so important for us to look at the whole environment in which that person works in. And so, obviously these are very leading questions, and maybe Beth, I'll get you to just comment on a couple of them, but I think the world is moving towards recognizing that we need to engage our patients in research from the very start. Vincent, you so often speak about Michael Katz and the influence he had in helping push us to do the lower dose DEX therapy. The role that we have here, even at the IMF, where the patient voice so often influences what we do, but we need greater patient engagement research, better measures and studies that prospectively look at quality of life, and key things that we can do that can truly impact the benefit of our patients in not only their progression-free survival or overall survival, but indeed their quality of life. So Beth, I'll just get you to make a few comments here, because I know this is an area in which you work extensively.
Yeah, absolutely. And I won't take too much time on this topic, although it is a very important one. I think that it's so important for patient-reported outcomes in research and quality of life in research. We have so many new therapies, CAR T-cell therapies where people can't drive for 30 days, bispecific antibodies where patients need to be admitted to the hospital. Who's going to take care of their dogs? So having that relationship and trust with the patient so you can discuss what the risks and benefits of treatments are, what are the short-term risks and what are the long-term benefits, I think are important, and the quality of life endpoints are really important. I love Dr. Banerjee's 24-hour analysis, because I've been in the myeloma space for 30 years, and we did not have the free light chain assay before 2004. And so 24-hour urines were so important for our patients who had non-secretory myeloma. But one of his comments on his oral presentation is there's no p-value in P, because of the fact that it really didn't add anything less than 1%, it changed the secondary analysis. So again, looking at why are we doing these assessments and what is the outcome? So hopefully his research will change the way that we measure outcomes, just like the MRD assessments with the Black Swan Initiative. And I think Dr. Roscoe's work with the lovesick and examining the couple's interactions is so important as well. So again, not only do we need better information as to what the sequencing of therapy should be, should we do CAR T before, bispecific, or vice versa? We also need to look at the quality of life, because quantity and quality of life are both important to our patients.
Yeah, I think you said that beautifully. Nikhil, someone just asked the question, don't we sacrifice understanding quality of life issues by moving MRD as a testing endpoint? And I think, Beth, you've tried to capture saying that they're not desynchronous, that we want to look at these things together. And I think that the research community at large is seeing this. I purposely didn't have a whole section on health equity. I do so much work in the area in disparity, and at the IMF, we have our Empower program, which is designed to improve the short and long-term outcomes of African Americans with myeloma, because it really is now becoming central part of what we're doing, that we look at patient engagement is also something that influences, are we reflecting the race and ethnicity of our patients? 20% of patients in this country are African American. And so when you're creating all the clinical trial materials, does that reflect that diversity? Does that reflect the diversity of the population that we're serving? And are these patients being included in studies? And now we're thankfully, and meetings like ASH and ASCO and journals are starting to insist appropriately that these numbers be reported so that we see it, because we want to look at the whole of the patient and not just their plasma cell as we treat patients going forward. But Vincent, Nikhil, I'll allow you to make a couple of comments before we take a few more questions and wrap up. Vincent, any further thoughts around?
No, Beth summarized it so beautifully. I don't have anything else to add.
Same here.
Wonderful. Well, it's so wonderful to have Beth with us today. It's so wonderful to have each of you with us today. So I will give you 30 seconds each. If you were on an elevator and you were told, what was your biggest takeaway from ASH 2024? You've got your 30 seconds to do it. Beth, I'll start with you.
You had to go to me first.
Well, your picture's first there, right?
Dr. Mikhael, you highlighted all of the innovative abstracts that were presented. There were so many poster sessions, there were oral sessions, just the excitement around the advancing of science. So I can't pick just one of them, but I love the quality of life research that was highlighted. I love the international focus. There were so many international papers that were presented. I think stay tuned for the tri-specifics. That's what I'm excited for, the different targets that our patients will have access to, as well as better understanding the way we're using the current therapies that we already have. That's it.
Beautifully said. Dr. Munshi.
I think the summary of what presented at ASH and what you really summarize here is that there is progress in myeloma at every stage. Very prominently seen in smoldering disease for the first time or relatively newer. We are making changes there to even prevent development of myeloma to first, second line, third line and beyond. There is great hope about having new targets, new treatment and combinations. One of the study analysis Perseus, for example, says there could be 15-year and counting of survival benefit. And so incredible number being achieved here. And finally, I think using MRD and others, we are inching towards a cure if we are not already there.
Vincent?
Yeah, I echo the same. We have too many to pick one from, but the fact that 200 myeloma experts showed up at 6 o'clock in the morning for the IMWG breakfast tells you, the excitement as well as the collaboration in this community.
And I think what amazed me, Vincent, at that breakfast was people didn't move when we were having a conversation. People usually get up, go get an extra cup of coffee. People were fixated. And I think, Beth, you said it nicely. All of you have said it nicely. If I had to summarize what struck me this year is, having done many of these post-IMWG series with Dr. Dury and with others over the years, it seemed like at every ASH or ASCO or EHA, there was kind of, the big area that was a focus, whether it was late relapse, maybe it was early relapse one year, maybe it was frontline. This year, it seemed to be everything, that there was advancement at every stage. And it speaks, as you've said, Vincent, to the community in which we work. I apologize to the 50 people that have sent us questions. We've covered about a half a dozen of them. But as I mentioned from the start, we will do our very best. I host a Facebook Live every quarter where we just have the Ask Dr. Joe Anything. So I'm going to do my best to answer a lot of these questions later. I'm just going to take one for Vincent because it was asked 2 or 3 times in different ways. If Vincent, can you comment at all about the deaths in the Aquila study as people, because you commented, of course, that there were half as many on the intervention arm versus the active monitoring arm. Is there anything else you want to comment about the nature of those deaths of individuals, be it with or without active myeloma when it occurred?
As Dr. Dimopoulos presented at the ASH meeting, most deaths were due to progression and myeloma deaths. And it's very hard to go by attribution. Deaths are deaths. And that's why overall survival is overall survival. You forget everything about the cause, because once you start saying disease-specific mortality or particular causes of deaths, then you can make a mistake in why did somebody die from or what was in their death certificate or whatever. But that was the main thing. And as you saw, the p-value would be significant if we had a formal test of comparisons, but we didn't do that for the reasons of the pre-specified endpoints. But the hazard ratio being less than 1 tells everything that you need to know. And I think the 95% confidence. The hazard ratio itself was 0.52, which means the risk of dying was reduced by half.
Yeah, and I think that's the key point, is that when we look at those, it appears that, the vast majority of those deaths were because of progressive disease. So that's very, very encouraging. So thank you again for those who've asked questions. As I mentioned, you still can reach out to us in the info line by calling, by emailing, by using all of our social media networks, as we've discussed, whether it's LinkedIn, Instagram, X, YouTube. Please follow our YouTube channel. You might see a few too many videos from Dr. Joe, but there are lots of other great videos there as well that can help educate you. This presentation will be replayed. And for the person who asked the question, will the slides be available? Yes. We make our slides available. I think that's critical. I think it's important that we share information and have them available so they'll be available to you. Please, as we come to our close here in the last minute, you will see on your screen the opportunity to give us feedback. We would really love if you could provide that feedback to us and let us know what we're doing well and what we're not doing well that we can do better. Thanks again to our sponsors. And then lastly, my final commercial, just to remind you, again, encourage your patients to come to this. If you're a patient, come to this as well, and bring your family and bring others who are involved in your care, as we will do a similar but even more patient-friendly version of the latest myeloma updates on January the 8th at 3 p.m. Pacific. You can register for it online, and I'll be joined by these marvelous patients that you see here, along with Robin Tui, our Vice President of Support. So with that, I'm going to thank all those who've been involved in this program behind the scenes and those who are on the stage, in particular, Drs. Faiman, Drs. Munshi, Dr. Rajkumar. I just so grateful for the three of you, for what you do for this community, what you do for our patients, and for joining me today. We trust that everyone has learned a great deal today. And as you've clearly seen, our work is not finished yet. So much more to come. Thanks again for joining us.
Thank you so much.
Thank you.